but then we're going to move on. So this is the simple, that's the simple, easy one. The better one, the one that's going to give us much more information and give us a much better sense of what is it safe or unsafe for you to be able to do from an exercise perspective, is using the American Heart Association and American College of Sports and Medicine health screening questionnaire. Okay. Through this, using the answers on this questionnaire, we're going to do something called a risk stratification. And based upon people's answers, and we're going to walk you guys through all of them, okay, we're going to put you into one of three categories. We're going to decide that you're either a low risk person, a moderate risk person, or a high risk person. Okay. And so as you can see on the PowerPoint slide here, there is this rubric basically that is like a flow chart of how you answer certain questions. Is going to start you off in a certain direction, and then from there we're going to figure out what can go on. Now, based upon into which category you fall, that's going to have an impact on what types of exercise we believe it's safe for you to do with and without a physician's clearance or consent. Okay? So this is the best way to do things. Now, I will tell you that what I'm going to teach you guys today on this is a little bit of an oversimplification. This is the basic way of doing risk stratification. If you take exercise testing and prescription with Dr. Kellewan or Dr. Larson, you guys will learn there's actually an even more in-depth way of doing a risk stratification. Okay, we a couple of years ago had people that were taking both classes simultaneously, and they kept arguing with each of us about like why we were doing things differently, and we figured out that we were teaching them different things. I didn't realize they also taught the more advanced one in there. But this is generally going to be a perfectly good way of doing things. On your test, okay, later this week, on your test, on the final, okay, you're going to have to take a scenario where I give you information about a person or persons, and you're going to have to walk through the stratification, decide what are they low risk, are they moderate, are they high, based upon the information that I've given you, and then make some recommendations on kind of what things they do. So this is one of those things out of class that it's going to seem very straightforward, but we're going to practice it a couple of times, because seeing it on the screen, right, and you think that you've got it, and then actually seeing how someone answers questions, and then having to go on from there, they can be a little bit trickier. Okay. So when we go through all of this, and we'll pull one up, I'll actually pull up the form, and you guys can walk your way through it here once we kind of go through what it needs to look like. Okay. Much like with the PAR-Q, the first thing that we're going to do is this medical review. Okay. We want to ask questions, and there are questions on there when we get beyond demographic information on, do you have a diagnosed major chronic disease? Okay. Do you have cardiovascular disease? Do you have some kind of pulmonary disease that's been diagnosed by a doctor? Do you have a metabolic disorder? Generally, the most common metabolic disorder we're going to see is, are you diabetic? Okay. Now, there are plenty of other metabolic disorders. Some of the more common ones that people run across are like a thyroid disorder, okay? But then there are sometimes other ones that are oftentimes going to be related to kind of differences in hormone levels and those things, okay? But it's going to ask about those. If a person says yes, okay, I have cardiovascular disease, it's been diagnosed, okay, or I have a pulmonary disease, or I have diabetes, what you're going to see a lot of is, I have cardiovascular disease and I have comorbid type 2 diabetes. That's very, very common. Okay. If people have any of these things, boom, we're done. Okay. the person is high risk. All right. Doesn't matter what they put on the rest of things. Does not matter how active they tell us they are. Doesn't matter if they know what their VO2 max is and it's super high. It does not matter. If you have a diagnosed chronic disease, you must, okay, regardless of the person's age, you must get physician's clearance before we can begin doing any kind of exercise with these people. I don't care if it's walking. I don't care, if it's doing like hand grip exercises, it doesn't matter. Okay. From a liability standpoint, people that have these are at a markedly increased risk, markedly increased risk of having a heart attack or some other kind of sudden cardiac arrest during a bout of exercise. Okay. So if you have one of these major illnesses, do not pass go to your doctor. Okay. That makes you high risk. And I guess I should say, if a person is high risk, they must go to their doctor. Does not matter what we want, doesn't matter how low the intensity of exercise is, go to your doctor. Okay? Okay. Now let's say they do not have, right? They've gotten through that first part. They do not have a diagnosed disorder. The next set of questions are going to ask about what we call signs and symptoms. Okay? Maybe you don't have diagnosed cardiovascular disease, but maybe you have these signs and symptoms of cardiovascular disease. And that means that you probably do, in fact, have cardiovascular disease. It's just not been diagnosed yet. Okay? So again, if people have any of these signs and symptoms, they're going to be considered high risk. Okay? If you have angina with exertion, so you have chest pain with exertion, okay? If you experience unusual shortness of breath at any time. Now you may ask me, Dr. Black, what does unusual mean? And I kind of throw my hands up and say, it depends, okay? But unusual shortness of breath does not mean I just did 10 wind sprints and I got to catch my breath now, right? Like that's not unusual shortness of breath. But it might be things like I walked from the couch to the refrigerator and I'm really, really out of breath. Okay. That would be sort of unusual shortness of breath. Dizziness or syncope. Syncope is dizziness and fainting. All right. If people experience those two things at any point in time, then they're going to be a high risk. Occasionally you will see college age individuals. In my experience, it has tended to be, we will see very kind of small, very petite women that will sometimes experience dizziness or syncope. Because they're so small, they may have very, very low blood pressure, which is good in a lot of ways, but on like going from sit to stand and stuff, sometimes they have a hard time because their blood pressure is so low to kind of keep and maintain blood flow to the brain, so they get dizzy with all of that. Okay. Heart palpitations, or what we call tachycardia, which is an increase in heart rate. Tachycardia is increase, bradycardia is decrease. But so heart palpitations, high heart rate, or irregular heart rhythm. Okay. So we could look at these things and, you could say something and I could be like, I don't know, Mindy, do you know if you have an irregular heart rhythm? You don't have to answer that. That would actually be HIPAA information. But right, like if I ask you, like I'm just like, hey Mindy, do you have irregular? You're probably gonna be like, I don't know, Dr. Black. How would I know? What would that feel like, right?
Yeah, I'm not sure how to answer.
Okay, that's okay. It's sort of a rhetorical question in the midst of that. Okay. Has anyone ever had like heart palpitations or felt like you're having a panic attack or something where you're in a place where you just feel like your heart is just going boom, 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 and it's just kind of racing? Maybe because there is some obvious external stimulus, but sometimes it's not. I will have days where when my anxiety is particularly high, that I will kind of sit down and I will really feel like my heart is just kind of racing in that particular way. Okay. All of these things are going to be signs that there may be some irregularity in the cardiac conduction system. Okay. And if that's going to be the case, then you're again going to be at a marked increase in risk from everything. Mine is just from anxiety. I've had an EKG done, and I'm perfectly fine. I know that, but especially in older individuals, that may be a sign of things. The last kind of sign and symptom to be concerned about is called ankle edema. Does anybody know what edema means? Edema is a fancy word for what?
Isn't it swelling? Sort of
I'm
like
sorry,
if your
Kiana,
ankle
can you
gets
say that again? Ooh.
Oh, I was gonna say, isn't it swelling?
It is swelling, and I apologize whoever else was there. I think you said swelling as well. Yeah, edema is swelling. Okay, so if you have unexplained ankle swelling, right? You go for a walk, your ankles begin to swell up like balloons, or you're just sitting there on the couch and your ankles swell up like a balloon. And when I say swelling, I mean I do mean like they go from like normal to like really, really big. Okay. Sorry, you guys can see my socks there. Glad they don't necessarily have holes in them today. There are some common causes of this. Most of it is going to be peripheral arterial disease, and you're going to have kind of some issues with fluid and blood pooling in the veins, especially in the lower legs. And you're going to have poor circulation into those areas and have a hard time with venous return. This is not the same, or I mean, it may present as the same kind of ankle edema that is often seen when women are pregnant. Okay. But obviously, if you're pregnant and you get some ankle swelling, which my wife had quite a bit of a couple of times, that has an explanation, right? The other thing is that it's often associated with ankle edema is something called intermittent claudication. It really should be called intermittent claudication pain, okay? Claudication pain. And what this is also a sign of peripheral arterial disease. It's a sign of very poor blood circulation into the extremities. Okay, we very, very often will see this in like the lower legs and the feet especially. And so claudication pain is the result of a lack of oxygenated blood getting to a particular tissue. So what happens is we do a lot of anaerobic metabolism there, which produces a lot of lactic acid, which produces a lot of hydrogen, and that's going to lead to activation of those nociceptors. Okay, claudication pain is oftentimes going to feel like kind of a burning sensation. Much like if your muscles were burning because you were doing high intensity exercise, but it's not really in your muscles. It's just kind of down in your ankles and those kinds of places. Both the ankle edema and the claudication pain tend to come on during physical activity and then kind of go away at rest. But these are called signs and symptoms. Okay. If a person experiences any of these signs and symptoms, there's a very, very strong chance that they have an undiagnosed underlying cardiovascular disease. Okay. So if people answer yes, they report some kind of sign or symptom, again, they are immediately high risk. You must go to your doctor to get clearance to begin any kind of exercise, even as little as just walking. Okay. You have a known disease, you have a sign or symptom, you're high risk, end of discussion. Doesn't matter what your age is, doesn't matter how active you are, any of those things, you're high risk, go to the doctor. Okay. Does anybody have questions about that?
I have one.
Yes, Maddie.
So for the dizziness or syncope, I know, so you said that's for like typically women who have really low blood pressure and it'll kind of bottom out. But would that also be like I know there's people who, when they go to the doctor and have to get a shot or a blood test, they don't really know why, but they get really dizzy and faint. So
yeah, that is not, that's not the same. That kind of has a known sort of external cause. So my wife is that way, which made her being pregnant not the best thing. Like if my wife sees blood, she's going to pass out. That is from something called vasovagal withdrawal, And so you get this kind of uncoupling of sympathetic and parasympathetic nervous system inputs. And those are some of the things that help us control arterial diameter, which help us maintain blood pressure and blood flow to the brain. And so you see things and boom, like you faint and you pass out. So that's in response to some sort of obvious external stimuli. That would not necessarily be something that we would be that worried about for when you're exercising. Now, for the most part, if there are women that have people that have low blood pressure, this happens to my dad in a lot of instances too. Like you're going from sitting and you stand up real fast and you get a little bit dizzy. That's probably not particularly dangerous, but that stuff we might report as a sign or symptom, but the other stuff I would not. So you can touch my wife in the crease of her elbow and like she'll pass out. So it made having to give blood and have blood drawn and do a bunch of stuff when she was pregnant was like she had to get like psyched up for a whole week to get it done. So it's pretty crazy. And they of course would not let me do it. Like I worked for a summer as a phlebotomist. I'm like let me try to take her blood and do those things, and they would never let me do it. So probably good for them. Okay. Anything else? We good on this? Going once, going twice. Bueller. Okay. All right. So now comes the next thing that we have to look at. Okay. So if you don't have an obvious disease and you don't have any signs or symptoms, then you will not be high risk. Okay. You will not be high risk. I cannot emphasize this enough. Okay. So once we've gotten through those, the next thing that we're going to look at are going to be these behaviors or characteristics that we're going to call risk factors for atherosclerotic cardiovascular disease. Okay. And it's basically, these are things that are going to, if you have these or you engage in these behaviors, these are things that put you at an increased risk of having atherosclerosis, okay, especially atherosclerosis in your coronary arteries, that are going to potentially make you at a somewhat higher risk of having a heart attack during exercise, because that may limit your blood flow to the heart during exercise. Okay? All right. So we're going to go through these one by one. Normally, I would tell you that you just have to memorize these numbers because the numbers are really, really important. Okay? But for what you guys are going to get to do when looking at the case studies and when doing stuff on the test and everything, you will have these things in front of you. And so just kind of pay attention and kind of think about what the numbers may mean. Okay. So risk factors means it's just elevating your risk. Okay. If we're not going to be high risk, then you're either going to be moderate or you're going to be low risk. Okay. And so we're going to make the distinction of whether you are a low or a moderate risk for doing some kinds of physical activity based upon your age, okay, and the number of risk factors that you have, okay? So we're going to take age is kind of in its own separate bucket, and then the other 7 here, family history through prediabetes, those are going to be all taken together. Okay. So when we look at age, okay, if you are a man who is asymptomatic, okay, so you have no signs or symptoms, you have no diagnosed disease, but you are 45 years old or older, okay, you are going to be considered a moderate risk, right? Similarly, if you are an asymptomatic woman who has no known diseases, who is 55 or older, okay, then you're going to be considered. That's the cut point for moderate risk. It does not matter If you're a man who's 45 or older, a woman who is 55 or older, there's no other things. It does not matter what the rest of your risk factor profile looks like, okay? You can be perfect, pristine health, very, very active. Everything looks great. But if you're at or above these age ranges, you're considered a moderate risk, okay? So if I'm a moderate risk, what can I and can I not do without a physician's clearance? This is really important. If you're moderate risk, the moderate risk is going to look like what a person can do from having filled out the PAR-Q. You may undertake light and moderate intensity physical activity without seeking physician clearance, okay? So you can walk, and that's pretty much it. Anything that's above a walk, and you need to go get physician's clearance, all right? When you go to get physician's clearance, and we can all wring our hands about this, they're probably going to take a medical history. They're going to take your blood pressure. They're going to look at some things. They're going to look at a lot of the stuff that would be here in these other kind of risk factors if you don't have any diseases. And for the most part, you're going to be fine, okay? Realistically, even people that are high risk are probably going to be fine the vast majority of the time. But that's what we want to do to cover our butts, okay? A man who's 45 or older, a woman who's 55 or older, you're moderate risk, okay? I'm not quite there yet. I got a couple more years before I'm automatically a moderate risk and I have to go to the doctor and get things kind of done and taken care of. So why do you guys think the age for men is lower than the age for women? What should we take from that?
And have heart attacks earlier.
They have heart attacks earlier. Yes, that's very reasonable. What else? Anything else?
Does it have to do with where they store fat?
That's partially related to it, Corey. Sure. Although, to be honest, you could have a 45-year-old man who has no visceral adiposity or things, and they're probably still at a slightly higher risk than a similar aged woman, even if that woman did have some visceral fat. What do you guys think? You guys know who lives longer?
Women.
Women tend to live longer. Okay, good. Why? Anybody want to guess?
It's more common for a woman to like seek out help or to go to the doctor.
Okay, that's reasonable, Corey. You're saying that I might not want to go to the doctor just because I'm a dude? Like,
it's because
whatever.
it's like they're like,
I'm fine, walk it off.
is it maybe because like men usually put themselves more at risk by like lifestyle choices and stuff like that?
Yeah, in a lot of instances, Jordan, you're absolutely right on. And Corey, you're also right. Maybe less so among men of my generation, and especially so among men of y'all's generation that are going to be there. But like my parents and those things, you kind of think of the traditional, the man, the strong, silent type who doesn't ever want to talk about his feelings and what might or might not be going on or be wrong, and they will not seek treatment for things. That can certainly be a thing. But yeah, Jordan, in a lot of instances, and again, it's beginning to shift as kind of what are thought of as traditional gender roles and kind of roles inside and outside of the home are beginning to shift around. Men tend to maybe be a little more overweight. Men tend to be under more stress for a host of reasons. Although that is also beginning to shift, will have higher blood pressure. They may tend to eat worse and engage in activities that are going to put them at a higher risk. Okay, but the data tells us very simply that women do not tend to have heart attacks very often. You ladies just don't have heart attacks. I don't think we have the numbers in here. But in like college-aged women, there's like one cardiovascular event in like almost every million, like 1 in every million exercise bouts. And in men, college-age men, it's like 1 in every 300,000. Okay, and then when you get into like folks that are my age, in men it's like 1 in every 10,000, and in women it's some still astronomically higher level. So ladies, y'all just tend to not have heart attacks until much later on in life, if you're going to have them at all. And it's for kind of a complex reason. But that's good stuff, guys. Okay, so we have those. Now let's make the assumption, okay, that you've got a person who is a man under 45 or a woman under 55. So this is going to be, let's just say, what you guys would be able to do, okay? So there's going to be a series of 7 questions. There are 7 primary risk factors for cardiovascular disease that we need to know kind of how you're going to fare on all of those, okay? And there's going to be some of them where it's going to be very common that you won't know the answer to. And so we have to have a way to be able to kind of deal with the fact that people may not know the answers to those things, okay? So the first of those is what we call family history, okay? And so for family history, what this is going to get at is, do you have a first-degree blood relative, okay? So mother, father, okay, brother, sister. Do you have a first-degree blood relative, okay, who was a male that had a heart attack or some sort of what we call coronary revascularization, which could be a bypass surgery, it could be the placing of a stent, something of that nature, or sudden death? So do you have a male first-degree relative that had any of these things before the age of 55, okay, before the age of 55? Or do you have a female first-degree relative that had any of those things that occurred before the age of 65? Okay. So what we're going to do now is we're just going to make a tally on our 7 risk factors, and it's just going to be a yes or a no. Okay. So we need to kind of see how many of these risk factors we do or we don't have to make decisions. Are we going to be low risk or moderate risk? So the first one is family history. Okay. Commonly, people will confuse the 45 and 55 in age of the person we're screening with the 55 and 65 that is part of the family history, okay? But if you have a male or female first-degree blood relative that's had any of these at a relatively, what we consider a relatively young age, that's a risk factor because there's such a strong genetic component to cardiovascular disease. The second risk factor is cigarette smoking, okay? Are you currently a smoker? Have you quit smoking within the past 6 months, okay? Or are you exposed to environmental tobacco smoke? Now, the exposure to environmental tobacco smoke is significantly less common nowadays, okay? You know, but it used to be like you could just smoke inside at your job. Like you could be in the classroom smoking, or things of that nature. I know many of you are probably going to want to ask, well, Dr. Black, maybe we don't smoke. We know people that vape. Does vaping count? So for this particular screening, it's only tobacco smoking. So cigarettes, okay. Cigars, people don't smoke enough cigars often enough for it's really going to focus on cigarette smoking, okay? Do you smoke or have you quit within the previous 6 months? Some of you may be social smokers, right? Where if I'm out in a social situation, maybe every once in a while I will attempt to, or maybe I will smoke a cigarette. I was on occasion a person that might have done that when I was in college, and so that's not really what we would consider to be a current smoker. Okay. This is a person that smokes regularly, or you're going to kind of smoke, you know, you regularly smoked like every day over kind of a more prolonged period of time. Okay, so we're a yes or a no on current smoker. The third risk factor is, are you sedentary? So we're going to ask people very, very specifically about how much physical activity they're getting. Okay, so if you are not participating in at least 30 minutes of moderate intensity activity, okay, on at least 3 days per week for at least 3 months. So basically, you're getting less than 90 minutes of walking, okay? 90 minutes of walking, kind of brisk walking per week, okay, for the last 3 months, you're going to be considered sedentary. All right? If you are sedentary, that is a risk factor. Now, there's lots of ways to ask a person about that. I could simply ask and say, hey, Maddie, can you try to think back on whatever it is that you do? Write this down. There are some formalized questionnaires where we can do that. But again, most people will have a pretty good sense of where they are, okay? The next risk factor is related to obesity as defined by BMI, okay, or waist circumference. So if you are obese by BMI, so you have a BMI of greater than or equal to 30, or you have a waist girth, which we will measure as part of the body comp lab. If you have a waist girth of 40, if you're a man, okay, or greater than 40 or greater than 35 if you're a woman, that's going to be considered a risk factor, okay? And so for men, we measure waist circumference basically right at the belly button, okay? And for women, we're going to measure your waist circumference as what ends up being kind of the smallest circumference from about your belly button sort of up to your sternum, okay? In women, waist tends to be a little bit higher in that way, so we're going to measure there, okay? Our fifth risk factor is related to blood pressure. So it's, are you a hypertensive person? So do you have a systolic blood pressure greater than or equal to 140 millimeters of mercury, or a diastolic pressure greater than or equal to 90 millimeters of mercury? Now, this has to be confirmed by resting measurements on 2 separate occasions, okay? Or you're taking an antihypertensive medication, all right? So if you're taking the medication, then we're going to count that as a risk factor. Otherwise, it needs to be this. Most of you guys probably don't know what your blood pressure is, okay? You probably haven't had two resting measurements taken on a couple of occasions in the last like 6 months for all of this. So we'll talk about how we deal with things we don't know about in just a few minutes, okay? But that's hypertension. So if you're hypertensive, that's a risk factor. The last two are the ones that have the most kind of confusing numbers associated with them, but they're also the ones that typically a normal person will have no idea where they fall on these two. The first is called dyslipidemia. Dyslipidemia is referring to, do you have elevated levels of LDL cholesterol, okay? Or do you have super high levels of total cholesterol? So LDL cholesterol, the LDL stands for low density lipoprotein. HDL stands for high density lipoprotein. LDL is bad cholesterol. HDL is thought of sometimes or referred to as good cholesterol. So if you have elevated LDL cholesterol, that's going to be indicative that you likely eat a lot of saturated fat, and you may have some metabolic issues going on that are going to prevent you from metabolizing it correctly. But if you have an LDL level of greater than or equal to 130 milligrams of LDL per deciliter of blood, or an HDL level less than 40 milligrams per deciliter, or total serum cholesterol, which is LDL plus HDL, greater than or equal to 200, those are going to be considered risk factors. Or if you have a person that is taking a lipid lowering medication. Because anybody ever heard of drugs called statins? You guys ever heard of a statin?
Yes.
Judy, you've heard of a statin? Okay.
Yeah, like pravastatin.
Mm-hmm.
I used to work in a pharmacy, so that's why.
Okay, yeah, so you've clearly heard of those things. I want to ask you to share any sort of HIPAA things as it regards to this, but if you look at any list of the most widely prescribed drugs in the United States, there are going to be several statin drugs that are typically going to be in the top 5, okay? I don't know, it varies from year to year, but you're going to get Viagra or some kind of erectile dysfunction drug or drugs. You're going to get statin drugs, and then we're going to also get drugs for promoting insulin sensitivity in people that are type 2 diabetics. Okay, are very often the most commonly prescribed things, but common ones, Lipitor, Crestor, and their generic variants. But there are drugs that you can take that will help lower your LDL cholesterol levels. And they're very, very widely prescribed. They do work very well for lowering your cholesterol, but a lot of them have some, in some people, they have some very, very severe side effects that result in muscle wasting and things. And we don't have a particularly good way to screen you to figure out if you're going to be one of the people that responds badly to it. But very commonly prescribed medications, okay? So high blood pressure, blood cholesterol levels, especially LDL. The seventh one is what we're going to call pre-diabetes or diabetes, okay? So if you are diagnosed as a type 2 diabetic, you're high risk. But there's a group of people, and my guess is if we were to look at everybody in class, we would probably have a couple of you guys that would fall into the range of being considered a pre-diabetic. And so being a pre-diabetic just means that you're going to have somewhat elevated blood glucose levels if we look at them first thing in the morning before you've eaten a meal. We call that fasting glucose, okay? People that are diabetics have a difficult time lowering their blood glucose levels correctly after they've eaten a meal, okay? And so if you're a pre-diabetic, it means that you're not, you can lower them some, right? One of the ways that we diagnose you as being diabetic is that you have this inability to get it in. So you have these high levels of blood glucose, even long periods of time after when you've eaten. So this is also sometimes called impaired fasting glucose, which means that it's just elevated, it's too high, okay? So if you have impaired fasting glucose, that means that if we were to test you first thing in the morning before you've eaten anything, you're on about a 12-hour overnight fast, that you have a fasting plasma glucose level of greater than or equal to 100 milligrams of glucose per deciliter of blood, but less than 126 milligrams per deciliter. If you're over 126, then you're considered to be a diabetic, okay? The other thing that you can have is what we call an impaired glucose tolerance. Now, if you took human phys on the Norman campus, as part of one of y'all's lab, you guys did a glucose tolerance test where you drank a little bottle of a kind of high sugar fluid, okay? It's like some Kool-Aid, you drank it, and then you did little finger sticks and got drops of blood at these like either 15 or 30-minute intervals over the course of several hours. And you looked at how much glucose was getting into your blood and then getting removed from your blood after having ingested a known amount over, say, usually like a 2 to 3 hour window, okay? That's called an oral glucose tolerance test, and that can also be used to diagnose a person as being diabetic. So if you have impaired glucose tolerance, where it's not bad enough to be diagnosed as diabetic, but it's higher than normal, that's going to count as you being at risk for being a pre-diabetic, and that is a risk factor as well, okay? So here's what I want to know, guys. You guys can flash me sort of a thumbs up or something here. How many of you right now today, if I ask you to fill out this questionnaire, how many of you know what your cholesterol levels are? If you know it, give me a thumbs up. Okay? So none of you know okay. Nobody knows their cholesterol levels. I don't know my cholesterol levels either. The last time they were checked was like 7 years ago, and they were good, but who knows? Okay? How many of you know your fasting glucose levels or your glucose tolerance test results from like within the last 6 months? Anybody? Okay. So what do we do then? What should we do with you guys? Nate, what do you think? If I don't know the answer, somebody does not know the answer to something, what should we do as the person evaluating if it's safe to exercise?
Probably just stay on the safer side and maybe try to see if you can get him tested or something.
Okay, sure. That would be great if we could get an actual test done on them. And they make machines. We have a couple. We've actually talked about doing this as part of our labs, but they make little portable machines, and you can do a finger stick and get a couple of drops of blood, and within 15 minutes we can know what your cholesterol levels are, and we can know what your blood glucose levels are. You have to control when people are eating to make sure that you're going to get accurate results, but we could test them. That's right. What else could we do to be on the safe side? I think Nate's right about being on the safe side. What else could we do?
Could you just mark them as moderate risk, so then that way they have to have that physician's clearance to be on the safe side?
Okay, sure. We could just be overly cautious and say, yes, you're moderate risk. Okay. And what's going to tend to happen because of that, rather than just immediately calling them moderate risk, the accepted protocol is if someone doesn't know the answer to a question, we can't get an accurate answer, then we just count that question as basically a yes. We count it as a risk factor. Okay. So if you don't know your LDL or your total cholesterol and you don't know your fasting glucose, then we would just count those two as risk factors. Okay. Now, here's where things get a little tricky though. All right. Because I've not told you guys yet what the cutoff point, how many risk factors you get to have before you're going to be considered a moderate risk person rather than a low risk person. And so this is where things get tricky with how we deal with unknown information. Okay. So if you have 2 or more risk factors, 2 or more out of our 7, then you're considered moderate risk. If you have 1 or fewer, then you're considered low risk. Okay. And so I really want you guys to try to appreciate this, okay? Because it seems like every year on a test, every year with things, that people get this confused. 2 or more. You could say, yes, I have all 7 of these risk factors, okay? If one of you guys said, I'm obese, I'm sedentary, I'm a smoker, I have a family history, right? I have high LDL, I have high blood glucose levels, I have high blood pressure, you're still a moderate risk, okay? You're still moderate. If you do not have a known disease and you don't have a sign or symptom, even if you have all 7 risk factors, you're still just moderate, okay? Every year, somebody will answer one of the case studies in class, or they'll do something like, oh, well, this person has 6 of the 7 risk factors, so they're high risk. We can't do anything with them. And I truly appreciate why that seems like the right answer, but it's actually not, okay? So if you have 2 or more, you're moderate. 1 or 0, then you're a low-risk person. So you can imagine a scenario whereby we've got a person who does not know their blood pressure, okay? They do not know their LDL. They do not know their fasting blood glucose. And so if they don't know those things, we're left in a situation where, much like Kiana said, you've got 3 risk factors potentially. We're just going to call you a moderate risk and send you off to the doctor. Okay, that's a perfectly valid way of doing things. That's probably the easiest and the safest way to proceed. It's just assume that those things may be positive, send them to the doctor, and get physician's clearance before we want to do anything with them. Okay. Now remember, if you're moderate risk, you can still walk. So you could have a person do some things do some kind of light and moderate stuff while you wait. However, there is some guidance given by the American Heart Association and the American College of Sports Medicine on another way to approach, especially in young individuals. Okay. So in individuals that are under 45 if they're a man and they're under 55 if they're a woman, if if they are not sedentary, okay, if they're not sedentary and they are not obese by BMI, then we will typically not count not knowing their LDL cholesterol levels and not count not knowing their blood pressure or their plasma glucose levels against them. Okay, so if you're under the kind of age restrictions and you're not obese and you're not sedentary, then we won't count those against you, because the chances are, as you all will see when we get into cardiovascular disease, the chances of having elevated LDL and total cholesterol are going to really start to pick up once you're a man over 45 and a woman over 55. Similarly, blood pressure is going to tend to go up at those age ranges and those things. And so, and if you're not sedentary, it's especially if you're younger, it's really hard to have impaired fasting glucose levels. Okay, and we'll talk about why all of that. But if you meet those two criteria, you're not obese by BMI and you're not sedentary, then we can have some exclusions for not knowing those other variables. Okay. All right. Anybody have questions about that? Anybody have questions? So let's just say that I've got a person and they have one risk factor, right? Maybe they're a cigarette smoker. They've got one risk factor. They have none others. They're considered low risk. If a person is low risk, then we will judge that it is safe to have them do any kind of exercising at any intensity, any kind of exercise testing at any intensity can be performed safely. Okay, you could do a VO2 max test on them. You can do a 1-rep max test on them. Any and all of that stuff can be done. Okay, you do not need physician's clearance. If you're moderate, you can do, or you're moderate risk, then you can do light and moderate intensity activity. But if you're going to do like a VO2 max test or a 1-rep max test or anything that's going to be vigorous in intensity, they need physician's clearance. Okay. Questions about all of that? Okay. So the rest of the slide things are pretty straightforward. So let me kind of just tick my way through all of those. It's going to show those kinds of things. Safety, precaution. All right. So what we're going to do now is I'm going to put you guys into your groups. Okay. And I'm not sure how to do this, because if I put you in the breakout rooms, then we stop the screen share, don't we? You guys will not be able to see. So somebody in the group, somebody in your breakout room will need to pull up one of the slides and kind of look at and read out the stuff that's going to be on there. Okay, and you can share that with the other people in your group. So what I'm going to do is I'm going to stop my sharing. I'm going to pause, have this as part of everything. Okay, so we have a female who is 21 years old, smokes socially on weekends, okay, drinks alcohol 1 or 2 nights a week, usually on the weekends. She is 5'3", weighs 124 pounds, so her BMI is 22. She has a resting heart rate of 76 beats per minute. Her blood pressure is 118/72. Her total cholesterol is 178. Her LDL is 98. Her HDL is 57. We do not know her fasting blood glucose. She is currently taking oral contraceptives. She attends group exercise class 2 to 3 times a week. She reports no symptoms. Both parents are living and in good health. Okay, so let's take this in a relatively systematic manner. Okay, so let's walk through our things. Age-wise, what do we think? Does she have a chance to be low risk because of her age? Lindsay's shaking her head and saying no. What are the age cutoffs, Lindsay?
45 for male and 55 for female.
Okay, so she's clearly under 55, right? So maybe you misunderstood what I was how I was presenting it. Right, she's not moderate risk because of her age, right? So we can at least move on to our risk factors. Okay, let's work through our 7 risk factors. Okay, 1, family history. Does she have a family history?
No.
Preston, you said no?
Yeah. Both parents are living and no, no health problems.
Okay. Are we sure about that? I mean, we know that they're living, but is living the question?
No, it mostly says good health, and it doesn't say anything else. So I'm just assuming.
Okay.
It doesn't mention any other first
Right.
relatives.
Okay. So in that way, the information that has been given is a little bit vague. Okay. Like it doesn't specifically say she reports that her parents have not had, a heart attack before this age or that age or something. But we can make a reasonable assumption that she's okay on family history. Okay. What about smoking? Is she a smoker?
Yes.
Okay. Maddie, you went with yes. Did anybody else go with no, she's not a smoker? Because
we
it's
said no.
socially on weekends?
Yeah, we said no because it was socially on weekends. So it's not like a habitual thing.
Okay. So that's one that could somewhat go either way. I would probably default to that, yes, she's a smoker. 10 to 20 cigarettes to me is you're not really a social smoker. You're just an occasional smoker. And not that we have a really good hard and fast definition on all of that. But I would normally default to say, yeah, she's a smoker. Let's go ahead and we'll count that one against you. So maybe we have 1. Okay. Does drinking alcohol 1 or 2 nights a week, usually on the weekends, play any role in anything that we've got going on here? You guys think that matters? Was that one of our 7 risk factors?
No.
Okay, Preston says no. That's right. Okay, so no family history, maybe on cigarette smoking. The third one is she sedentary or not? You guys remember, so what's our definition of being sedentary?
30 minutes a day, 3 days a week for the last 3 months.
30 minutes a day, 3 days per week, okay? And it's moderate intensity activity, 30 minutes per day. So what do we think? Do we think we have enough information to know if she's sedentary or not?
We said she wasn't because she has group exercise class 2 to 3 times, and usually an exercise class is around an hour, and it's usually more intense than just walking.
Mm-hmm. Yes, that's what I would go with on all of that. But I hope that highlights to you guys, again, that specificity of the information that is given in the questions that we ask needs to be a little better. So yeah, I would argue like you guys that 2 to 3 times per week exercise classes are usually an hour, where you're probably going to get 45 to 50 minutes of actual work being done. And unless it's walking class or something, you're probably getting some vigorous intensity activity in there, and that's going to totally blow us out kind of whatever we're going to need there. Because really, if you're getting 45 or 50 minutes of vigorous intensity activity in a week, you're not sedentary. Okay, so she's not sedentary. Okay, so what about her blood pressure? Is blood pressure an issue?
No, it's not.
Okay, blood pressure, so it's 140 or greater or 90 or greater, so she's okay by blood pressure. So what's about her cholesterol levels?
Those are good.
Her cholesterol's good, right? Her LDL's not over 130, her total's not over 200, and so we're fine there. We do not know her fasting blood glucose. We're going to come back to that one. Our only other risk factor is obesity by BMI. So what is her BMI?
22.
22. So is that a problem for us?
No.
Is BMI a risk factor? No. Okay. So we don't know her fasting blood glucose. So remember, let's try to do the more complicated version. We could say we don't know it. We're going to count it as a risk factor. And if you then counted cigarette smoking as a risk factor, then she would have 2 and she would be moderate. However, we don't know it, but she is young. She's 21. Okay. She is not obese by BMI. She is not sedentary. So we wouldn't have to count fasting blood glucose as one. Okay. So when I look at all of this, I see that she has either 0 risk factors or 1 risk factor if we count smoking as those things. Either way, that to me makes her low risk. Okay. So we can do any kind of exercise with her that we would like to do. Okay. All right. Do you guys have any questions about that? We've got a couple more that we will go on and do. I'm going to pause the recording. Okay. Okay. Case study number 2. Okay. Case study number 2. Someone from the group that said they were low risk. Tell me why you guys had them as low risk. Run me through things.
We had that his only risk factor was his age and that he was over 45 years old, because we saw that his parents both died, but they died after the age cutoff. Like whenever on the family history, it said if they died of a cardiac incident before age 55 for men and things like that. And he died when he was 77 of a heart attack.
Okay. So you had him at 1 risk factor being age.
Yes.
Okay. Someone from one of my groups that had him as moderate. What were you guys thinking?
We said moderate risk because everything else was clear, like everything was a no.
Mm-hmm.
But you told us to kind of separate age and the other 7, and that if they were over the age, then they're automatically moderate risk. So that's why we said moderate.
Okay. So, Maddie, y'all were right that he only has one thing that is age. But we just need to remember that age stands by itself. So you guys could have read the first 4 words on here and been done. That's it. Okay. So he's 54 years old. Now, I guess you could have had to read the rest of it to know, like, does he have any signs or symptoms or diagnosed things? But he looks really, really good from all of his other risk factors. He's in good shape. He's very active, all these kinds of things, but he's 54. So he's considered moderate risk. Okay. He's considered moderate risk. And that highlights the importance that age is kind of over here by itself, and then all of our other 7 are going to be over here. And age trumps all of these other ones. Okay. Age trumps everything in that particular regard. All right. So my guess is, and this is part of why the case studies are set up the way that they are. We got these out of a book, and these are some of the ones that we've chosen to give you guys, as it kind of highlights some of the intricacies of how we do all of this. Okay. Okay. So very good. So let's do one more. All right. Let's do one more, and then we'll wrap up for the day. So I'm going to stop sharing. I'm going to resume recording. I'm going to share again, and I'm going to close all the breakout rooms. Just make that go away. And did I miss it? Did you guys write in the, like, put in chat what you think the group this one is? Moderate. Somebody's got high, it looks like, on there. Okay. Excellent. So we got a little bit of disagreement again on this one. So let me pull up the chat one more time. Okay, so I got a couple of people that are saying high, a couple that are saying moderate. So let's walk our way through this one. Okay. So Keeping the last one in mind, we have a man, he's 44 years old, okay? So what do we think about that? Is he okay by age? Is he going to be definitely moderate because of age, or do we have a chance because of his age for him to be low? Age doesn't tell us much about high risk at this point. So what are we thinking about age?
Is good.
He's good. That's right, Whitney. Okay. So going through our next ones, we've got family history. Okay. Family history. What do you guys think about family history? His mother's living.
I have a question.
Fire away, Whitney, please.
I just need some clarification. So is it like an and or thing, or is it say that, you know, I guess this example, his dad died at 67 of a heart attack, but does that mean, does he have to have a heart attack before 55?
Yes.
Or
yes.
is it a heart attack period?
No, it's a heart attack if
55.
a male first degree blood relative at before 55 or a female before 65. Yeah.
So they can die of whatever as long as it's after 55.
Correct. So they can have a heart attack at 56, and that will not count as
doesn't count.
That's right.
Cool. Okay. Thank you.
You got it. This is why we do these things, right? So, okay. So family history. His father died of a heart attack at 67. His mother is living. She has no cardiovascular disease, which we're going to assume then she has also not had a heart attack. So as family history goes, he should be okay. So he's okay on age. He's okay on family history. All right. Is he a smoker? No, not a smoker. Okay. So we're good there. Is he sedentary?
We said he was.
We said no.
We said no.
Okay. So Kiana, your group said no. Why did you say no?
Usually, I guess, like, on average, if you're just walking, like, walking a mile takes around, like, 20 minutes. And if he's walking that much, like, 2 to 3 times a week, he's going to pass his, like, the sedentary mark of, where was it?
90 minutes.
90 minutes a week.
Okay.
And if he keeps doing that, over probably 3 months.
Okay, that seems very reasonable. Did anybody interpret that as maybe he could be sedentary?
We did.
Okay.
We did.
What was y'all's thinking on that? How did you guys kind of conceptualize that then? Just it's not enough, or what? How did you kind of draw that line and make that distinction?
Our group, we just said that it doesn't really distinguish between walking or like a brisk walk because it says it needs to be moderate intensity.
Mm-hmm.
So we just went with like the safer bet of no, or yes, he is sedentary just because, yeah, he walks a couple miles, but we don't know how fast he's walking. So that's why we went with that.
Okay. So knowing how fast he's walking is, and kind of what the intensity of that is a really important missing piece of information. Although, to be 100% honest, it's hard to walk so slow. My wife yells at me because I walk super duper slow. And have I told you guys that my wife is 5'3" and I'm 5'10" and our waist occurs at the exact same height? So, like, if you guys could see me, I'm all midsection with these little like baby T-Rex arms and little short stubby legs. And my wife has no midsection, and she's 5'3" and sometimes like has to like can't. Anyway, she has a hard time buying pants, but she's all arms and legs. And so we're kind of hoping that Ellis is going to get kind of right in the middle of us. But my wife walks super fast, and I walk really slowly. That was the point of that story. And even as slow as I walk, it's probably going to be considered moderate intensity activity to walk. I mean, you've really got to putter around for it not to be moderate. And even at kind of the slow end, where maybe you're at what Kiana was suggesting at like 20 minutes a mile, which I was going faster than that with the stroller this morning. And my wife tells me that I'm like watching paint dry with the stroller. So she walks and she does like 13 and a half minutes a mile when she walks. She basically runs. So that's probably still moderate. So just kind of keep all of that in mind. It's certainly not a wrong thing to say that maybe he could be sedentary. We don't have enough information. But just kind of as someone that encounters more of this, it's very, very unlikely that people, if they formally go out and do walks, that they're going to go slow enough for it not to at least be moderate. And even at that, it's 2 or 3 miles, and maybe it's going to be 30 or 40 minutes if it's 2 miles, or maybe 45 minutes if it's 3. And so it's going to be tough. Okay. All right. So we're there. So sedentary is a maybe. We could potentially go either way with that one. Okay. Is he obese by BMI?
Yes.
That's correct. He's obese by BMI. His BMI is 31. Okay. We don't care what his resting heart rate is. Let's look at his blood pressure. What does his blood pressure look like? Okay. 128 over 84. So is blood pressure going to be a risk factor? No. Blood pressure is not going to be an issue. Okay. His total cholesterol levels are 184. His LDL is 106. Are either of those numbers going to be problems?
No.
And the 3 of y'all that I can see are saying no, that's right. Okay, so LDL is not an issue. Okay. So we've done family history, which is a no. We've got smoking, which is a no. Sedentary is a maybe. Obesity, we're obese by BMI, that's 2 for sure, or that's 1 for sure. Okay on blood pressure, okay on those. All we're left with then is fasting blood glucose. We do not know his fasting blood glucose, okay? So how should we can either just say we don't know it, it's a risk factor, which would for sure give him 2, no matter what we do with his sedentary things. Or what could we try to do if we were going to do something else? So he's under 45, so what might we be able to try to do? How do we interpret that?
You could say if he's under 45, he's not obese and he's not sedentary, you don't really have to worry about it, but he is obese by BMI and the sedentary is a maybe. So we went ahead and marked it as a risk factor.
That's correct. That's absolutely
Plus,
correct.
Plus his dad did have type 2 diabetes, so there could be like some predisposition to that as well.
Absolutely. That's a very, very good catch, guys. So based simply upon the fact that he's obese by BMI, we could not count it. We can't just ignore it because we don't know it. Especially because he's obese by BMI and his dad had type 2 diabetes, then for sure we would want to count the unknown as being a risk factor. Okay. So at the least, he's got 2 risk factors. Okay. Depending upon what we do with being sedentary, he might have 3. So if he's got 2, what would that make him?
Moderate risk.
Moderate. Okay, good. If he's got 3, what would that make him?
He would still be moderate.
He would still be moderate. Okay, he would still be moderate. So I know a couple of my group said that he could be high risk. Walk me through how you guys were interpreting that he might be high risk.
I think we added 1 because his dad died of a heart attack, but I think the age thing on that is where we added that extra risk factor. We misjudged.
Okay. So just remember, okay, unless you have a diagnosed disease or you have signs and symptoms, then you cannot be high risk. It doesn't matter what you have a family history of. It doesn't matter how many of your other risk factors, even if you had, as I said, even if you had all 7 risk factors, if you do not have a diagnosed disease and you don't have signs or symptoms, you're not high risk. Okay. So high risk is pretty rare for a lot of people that we're going to encounter. Okay. So there we go. All right. I'm going to stop sharing. I'm going to